And we are now live.
All right, this is Senate Health and Welfare. We are back on S37 and we're continuing markup with our ledge council on page 16, I think, Senator Jen Carvey. Why don't you go ahead, Senator?
Thank you for the promotion. Jen Carvey, Legislative Council. Yes, we are on page 16 toward the bottom. This is the draft, same draft that Amron was walking you through earlier. Draft 1.3 of a markup version of S37. And so the first section that I worked on that we've come to is on emergency contraception. And you may remember in the original iteration, and you'll see it kind of struck through. Oh my God, I didn't even put it in here. The earlier version that is no longer even in here for you to see because it was confusing. It was about allowing pharmacists to dispense emergency contraception pursuant to a standing order. So instead of creating a new subchapter on emergency contraception, I'm instead in this version amending existing subchapter 1 of 26 VSA chapter 36. That whole chapter is the pharmacy chapter. And first thing I've done is to add a definition in 26 VSA section 2022. And that's a definition of emergency contraception, the same one we had in the earlier draft. Any drug approved by the FDA as a contraceptive method for use after sexual intercourse, whether provided over the counter or by a prescription. And I included the over-the-counter drugs in here because if they're prescribed, they can be paid for with insurance. So you can decide, and the insurers may have suggestions for you on that, but that is what it means currently in here. And then instead of the new section with the Commissioner of Health issuing a standing order and the pharmacist dispensing and there being various immunity provisions that we had looked at in the earlier version. This instead just puts emergency contraception in with an existing provision of state law, allowing a pharmacist to prescribe medication in certain contexts. One of them is pursuant to a state protocol that has been approved by the Commissioner of Health after consultation with the Director of Professional Regulation and the Board of Pharmacy and ability for public comment. There are a number of medications currently on that list. The two that are not highlighted are existing ones. I'm just taking "and" out of one list and putting it, or out of one item and putting it into the next one. And this would add emergency contraception then as medication that a pharmacist could prescribe, order, or administer in a manner consistent with the state protocol. And you'll see in the effective date section, I think I had this take effect on, not later than September 1st upon approval of the state protocol by the commissioner. I don't know if that's a realistic date. It's the date we had in the earlier version for coverage or for the authority to start, but the health department may have a take on whether adding this emergency contraception in would be a longer process than that, or if that works for them as kind of a deadline.
Or we should get back to David Engler about that. What's the date?
It's in the effective date.
In the effective date
So it's at
section.
the very end.
of the
Gotcha.
Yeah.
Okay.
So
And
Jen's
so-
just
yeah.
identifying
So
it for us.
we'll get there, but what I said is that it would take effect on or before September 1st on such date as the Commissioner of Health approves the state protocol.
Okay.
And then in what was a second new section in the new subchapter, I'm no longer adding, so it's now its own standalone section 11A, adding 26 VSA section 2077. This is the vending machine language. There was no change to this except to say that the Board of Pharmacy may adopt rules instead of shall adopt rules, because I think you heard from OPR that they believe retail and institutional drug outlets can already make these products available through vending machines. And they said if they were going to adopt rules, there would need to be, or they may not need to adopt rules, or they may need to do certain things before they can adopt rules. So they wanted it to be permissive. I did reach out to the University of Vermont and Vermont State Colleges and OPR, because I think some of the testimony you've heard from Planned Parenthood was that these are most commonly done in other states' bills on college campuses. I reached out to them to ask if they had any thoughts on that, and to my knowledge, I did not hear back. So I have not made any changes at this point to what was already in here, but we can certainly look at that if that's something the committee is interested in. All right, then we get to section 12, and these were the readiness plans. We had access to reproductive and gender affirming healthcare services with readiness plans, and I've pretty significantly revised this to really scale back what it's asking for. I think there was some confusion with the previous language, which had come from Massachusetts, about whether a readiness plan was a plan to get to a certain later point, or whether it was, I was sort of envisioning it more as like a security plan where you just spell out what the steps are that you have in place, but it doesn't necessarily mean you're planning to get somewhere other than where you currently are. But regardless, change the language. And we made it, instead of being specific to medication abortion readiness, it's more broadly around reproductive health care readiness. I think you've heard some testimony from various witnesses that seemed like an appropriate expansion if somebody wanted to support maintaining a pregnancy as well as terminating pregnancy. So, so this would start out with the definitions, still adding a new chapter in Title 16, the education chapter. Did not make any changes to the definition of gender affirming healthcare readiness, or gender affirming healthcare services or institution, or medication abortion. But I took out the term medication abortion readiness, and I instead added reproductive healthcare services, specifying that it has the same meaning as in the beginning of this bill, 1 VSA section 150, and includes medication abortion. And then I have reproductive healthcare readiness being each institution's preparedness to provide reproductive healthcare services to students or assist them in obtaining reproductive healthcare services, including having in place equipment, protocols, patient educational materials, informational websites, and training for staff, provided, however, that reproductive healthcare readiness may include the provision of reproductive healthcare services. So it was the same idea that we were looking at as far as what the scope of readiness means, but applying it to the broader context of reproductive health care services. And then, and this is sort of a little bit of a messy markup to find your way through, but this new section would now be gender affirming healthcare and reproductive healthcare readiness and reports. And this would have each institution, which was defined as the Vermont Public Institutions of Higher Education, report to the Department of Health annually on or before a date certain. I put a date in here, but you can certainly change it. On the current status of its gender affirming healthcare and reproductive healthcare readiness, including the types of services and supports it makes available to its students. And then on or before January 31st of each year, the Department of Health shall, and if you skip to line 17, compile the materials submitted pursuant to subsection A. So compile what they got from the institutions and report to a number of committees, including this committee. So I have House Education, Healthcare, and Human Services, and Senate Education, and this committee on the status of gender affirming healthcare and reproductive healthcare readiness at Vermont's institutions. And that would be the end of that section. And then section 13 just has the implementation of when those would start. And since it's just a report on what they have available, I made it start this year instead of next year, and said each institution shall submit. So sorry, we're on page 22 if I'm going too quickly. Each institution would submit its first report on the status of its gender affirming healthcare and reproductive healthcare readiness as required under that section 16 VSA 2502A to the Department of Health on or before November 1st of this year, and the department would provide its first legislative report on or before January 31st of next year.
Thank you, Jen. This is clearer and is consistent with what we heard. However, I'm wondering by striking out all of the stuff that the Department of Health was supposed to have provided guidance on, we're losing some of the things that we want to make sure the institutions themselves are taking into consideration in their readiness reports. I understand Department of Health's concerns about not wanting to have to issue all this guidance. I get that. But I'm wondering if we could add language in the
Criteria for
criteria of
evaluating.
what reproductive healthcare readiness and gender affirming care readiness means, that it would need to include such things as, you know, the availability of referrals, the travel time and transportation issues.
So are you looking at maybe putting back in a slightly different way that language is struck through on page 21, where in developing the guidance, the department would consider certain factors and instead having the institutions providing this as part of their,
Yeah, exactly.
that makes a lot of sense.
Makes a whole lot of sense. That's good.
I can do that.
Yeah, I mean, I do think, oh, sorry.
Yeah, no, go
I
ahead.
think if you're in sort of a, for lack of a better term, like a healthcare desert and you don't have a vehicle, you might need to be driven, you might need to be driven to a place where you can get the care that you require.
Yeah.
Right, and also, I mean, sorry to,
No, go ahead.
I don't know if this was already in here, but broadband access or something, if they're gonna do telehealth.
Right.
Because I know a lot of this care can be provided via telehealth, but if they don't have good access, presumably at higher education.
That's what I was gonna say, I would
Yeah.
expect
Yeah,
it, institutions that would be,
Especially in the
Something that can address.
libraries that are. No.
Oh,
Now that there's no libraries.
Oh my gosh.
New use of the facility.
okay, but I do hear you saying also just some interest in, if we're not having the health department developing this, that maybe thinking a little bit more about the types of access questions you would want them to address. So
Yeah,
so if you have thoughts, I'm happy to include them. I'm happy to also think about things like, we had talked about public transportation, but I don't know that it's specifically in.
Sounds good.
Oh, it is, and
Page
cost of
22.
It's in the,
Yeah.
yeah.
So something about transportation and access to telehealth, maybe just
Okay.
putting it in generically.
Yeah.
And then, you know, the ability the proximity to hospitals, clinics and other facilities, that's at the bottom of page 21, sort of some.
Right, yes, I'm thinking I will add in all of these
Yeah,
A, B, C, D, to A, B, C, D. And we can add a reference to access to telehealth
Okay,
or availability of.
so the question is then, we're putting that in as part of the readiness plan process? Or are we putting
not
that
doing
in as the Department of Health evaluation? How are we?
No, we've taken out the Department of Health evaluation. So really what I would see this looking like is on page 20, where we say each institution shall report to the Department of Health annually on the current status of its gender affirming healthcare and reproductive health care services, including, and then probably
Listing all
just,
that.
right,
That's
the
what
types of
my-
services and supports it makes available to its students, whether they have a
All that.
health center, yes.
exactly, yeah.
Yeah,
Yeah.
that
So
makes a
then it's
whole.
on
I think
UVM and
that's-
Yeah.
colleges to do it, not on the department.
Right, exactly.
Go
But
ahead.
it's very
This
clear,
is
it would be
conversation,
much
discussion time.
clearer
Yes, discussion time.
to the institutions than I think they felt it was in the previous iteration, what they were gonna be asked. I mean, it'll be
Yeah.
listed right.
I just want to say that this part of the bill really feels like a birthday present to me. Because, you know, having been in college in the 80s, when I often felt as a young woman, like just completely alone and abandoned, this to me is, I'm so happy.
Yeah,
So
good.
happy it's in here. I think it will be, just a great thing for young people.
It
I
is
just thought of
reassuring.
another thing that, speaking of your experience in college, that reminded me, maybe we wanna add, I'm not sure how to word this, but what are the universities, what is the university and colleges doing to educate students on
Has education. Oh,
basically crisis pregnancy centers, so that they're
Yeah.
not sending students inadvertently to these, to non,
Yeah.
non-medical facilities or facilities
Because they
that
weren't
don't
educating
provide
us.
comprehensive reproductive care or something
Yes,
like
they're
that.
not educating us in the 80s, I can tell you that much. Was it you? Someone told me they are now, they're very much aware of. But
Depends on the
you're right, I don't
institution.
know.
Depends on
I
the
can tell you that
institution.
Middlebury College has issues with this,
Okay.
because they're not providing
So that's a good
appropriate guidance to students.
But remember, Middlebury is a private institution.
Yeah, no, I know, I'm
It's
just
not
using them as an
under
example.
our umbrella.
Yeah.
Okay, so, but I
Just walk over there.
I think we could say something like, what they do about referrals, including the scope of the information they provide, or the information they provide about the scope of services available at.
Yeah, the scope and,
Yes, he
I
was.
don't want to say accuracy, but.
Yes, he is. Go ahead.
I'm just concerned a little bit about with the report. I understand the intent, but I'm a little concerned about if the report, how is he, what the criteria for evaluations? I mean, what's the right answer? For example, transportation. Are they, as a state,
There's no right answer. I mean,
But I know,
it
but
could
I-
be that there's no
that's the
transportation. I
problem.
mean, so that's something that we can hear about. And then maybe is there an appropriation that the college asks for that would enhance transportation services? Or maybe there's a recommendation about other issues there. There's no right answer here. It's simply an
But
opportunity.
We're making it up.
Here. The right answer is, we've got a readiness plan, but we have some gaps. I mean, that's what
Right, I think what you're asking for is the information so that you can, to some extent, be doing the evaluation of, does this seem appropriate? Does this seem reasonable? Do we need to do something to address access to transportation? And if, you may start looking at access to transportation and realize that's a broader issue you want to address as far as transportation for a number of services around the college.
for
but there's no checklist, except you have this or you not, and have you thought about what you might need? It's
This
the
is-
beginning.
There's a certain point though where the individual has
Oh, yeah.
to stand up and
Take care of him or herself.
Which individual?
It's,
I think
that's the
sometimes
next
when-
conversation.
when we get reports, and we sometimes ask for too many reports, I will say that on the record, but sometimes it's important to get a report and just to have the information available publicly, and maybe we don't even act on it, but there could be providers in the community that are like, oh, I didn't realize that students at Castleton didn't have access to this type of thing. Let's work with Castleton University to help solve this problem together. I mean, it was really clear when we got testimony from the two institutions that UVM has a pretty comprehensive network and support system and plan in place, but the state colleges don't. And so just the act of doing the report might help them answer some of those questions.
Okay, so is there a component of the readiness plan? Do we know what the components of that plan are? Does it address transportation? Does it address?
So not a plan.
Okay,
And this
so,
is just a report. This is kind of a status report of what are they offering and have available now. There may be changes from year to year because you've asked for it to be annual, although it will likely sunset at a certain point, but,
so you could get 5 to 15 different reports, depending on, if somebody doesn't tell them what we're asking.
well, you're asking them what to read, or you're telling them what to report on, but you're not telling them if the right answer is, yes, we offer that, or no, we don't offer that. Sort of prompting them to think about things if they hadn't already, and to tell you what they're doing to address the issues you've identified.
And there are mitigating circumstances for each institution. So UVM is sitting in a very unique spot. So, Linden, Johnson, or Castleton might be different. St. John.
All right, you want to take a quick look at this last section before you have to
Yeah.
move on?
We're good.
Okay.
We're good.
So this is the section 14 on prohibition of undisclosure of protected health information. And
Oh, good.
I didn't try to show you how each of the words change. There's a lot of changes in here. And big thanks to Jessa and a few other stakeholders who worked with me on some revised language. May have a couple of little tweaks coming from Michelle Childs, who you heard from yesterday, just to make sure the language is meshing well with other provisions of our law. And she's also sent it to Judge Zone to take a look. But this would do a few things. So this is
So this whole section, just to clarify, the whole section is rewritten
I just wrote rewritten and then I gave you the old one struck through.
and the old one
was
is in yellow.
Too complicated to try to,
No.
I would have
sorry.
highlighted the whole thing. It was too complicated to try to show you these words. Most of the words changed, but some of them are just reorganized a bit. So we're on page 23, and this is in the disclosure of protected health information prohibited. So the first thing in the definitions is that I've added a definition of business associate and then used that term. This was a request that had come to you from a number of different witnesses, both written and in testimony in committee. That's a term that is used a lot in the HIPAA context and along with covered entity. And this would then cover not just the covered entities, but business associates of theirs who might also have access to protected health information because they're involved in billing or something like that. So we add a definition of business associate, tracking the same definitions from federal law as exist in existing statute for a covered entity. And then we pull in that definition of legally protected healthcare activity that we're using throughout this bill and H89. Protected health information is that HIPAA definition again. So as far as the existing language, existing statute, we have just adding the business associate. So a covered entity or business associate shall not disclose protected health information unless the disclosure is permitted under HIPAA. And then here's our new language. In order to protect patients and providers who engage in legally protected healthcare activity, a covered entity or business associate shall not disclose protected health information related to a legally protected healthcare activity for use in a civil or criminal action, a proceeding preliminary to a civil or criminal action, or a probate, legislative, or administrative proceeding that is adverse to a patient or to a patient's healthcare provider, unless the disclosure meets one or more of the following conditions. The disclosure is authorized by the patient or the patient's conservator, guardian, or other authorized legal representative. So if the patient says it's okay, it can be disclosed. The disclosure is specifically required by federal law, Vermont law, or rules adopted by the Vermont Supreme Court. The disclosure is ordered by a court pursuant to federal law, Vermont law, or rules adopted by the Vermont Supreme Court. And an order compelling disclosure under this subdivision must include the court's determination that good cause exists to require disclosure of the information related to legally protected healthcare activity. The disclosure is to be made to a person designated by the covered entity or business associate and will be used solely in the defense of the covered entity or business associate against a claim that has been made or there is a reasonable belief will be made against the covered entity or business associate in a civil or criminal action, a proceeding preliminary to a civil or criminal action, or a probate, legislative, or administrative proceeding. Or our last instance where the disclosure can be made is that the disclosure is to the Board of Medical Practice or the Office of Professional Regulation as applicable in connection with a bona fide investigation of a licensed, certified, or registered healthcare provider. So one of their people they regulate.
One little edit.
One little edit, but luckily I'm in the document, so I did.
Okay, so this, and so I'm thinking that Michelle has probably looked at this, this stretches into judiciary.
Right, so I sent it to her last night and she may have a couple of I think,
Yeah.
non-substantive
Okay.
changes. She has sent it to Judge Zone.
Yeah,
I had sent it to OPR, Board of Medical Practice, Medical Society, Hospital Association, a few of the other experts we've been working on some of these things with around the country, not knowing really, frankly, who is the best HIPAA expert, but
Yeah.
explaining our goal and what we were trying to get at. And so that was really helpful and feels a lot more operational
Sure
as
does.
written than I think what we had before.
Question from someone who is on a steep learning curve. Is reasonable belief a term used in the law that, yeah,
Yeah, I mean, reasonableness standard is fairly common in statute and in the legal world generally. It's subjective, but it, if it comes to it, it's up to a court to determine what is
Yeah.
reasonable.
seems really subjective, but I'm sure.
Yeah.
It's really what a reasonable person would believe under the same circumstances.
Got you. And what would that look like in terms of a claim that has not yet been made? Might be, like, what is?
Right, somebody may have gotten notice that that a claim is coming, or that or an investigator has scheduled an appointment, or there may be something that indicates that legal liability is coming. Yes,
Okay.
it's forthcoming.
Great, thank you.
Okay.
Somebody else on learning curve, procedurally, H89 and this bill
Yes.
are pretty close. What's the likelihood that both of them could pass and become law? Is there gonna be a conflict if they do?
No,
No.
that's that's the whole point. I'll let Jen respond.
Yeah, so that's actually, we're working closely with Michelle, and that's why she came in to talk to you yesterday, and why Ameren and Michelle and I have been working together. These are really complementary pieces of legislation that are designed to work together, but because H89 focuses more on judiciary issues, the judiciary committees are focusing on that, and this one relates more to the practice of medicine and to patients and providers, and healthcare. And so you're looking at it in here, but I think they will either join up together down the road, or they will be enacted together and not conflict.
So will this bill have to go through the judiciary?
That's a question for the chair and your leadership.
I'll be working with the chair of judiciary, and I'll ask him to look over sections of the bill. And if they feel they need testimony, they'll do that. So there will be an opportunity for us to be in sync.
Ask Jen a question.
Yeah.
So in paragraph 3 on page 24, where it references ordered by a court pursuant to federal law, given that there aren't federal protections for these types of healthcare in federal law, is there a chance that federal law will
Preempt us?
I don't know that we would be able to prevent a disclosure being made if a federal court or court ordered disclosure under federal law. So I think this is a recognition of the limitations on what we can restrict. And what you can see is being left out of here is a disclosure ordered by a court pursuant to the law of another state.
I see, yeah, okay, thank you.
So I'm gonna suggest that we wrap up here. We'll come back to do continued markup on the bill early in the week, as soon as we can next week. And, thank you, Jen. This is very helpful.
Great,
It's really good. That was a difficult section, I know.
it was, and many
Sorted
thanks
over
to
that.
Jessa and others who have been.
And we do have folks who come in, and welcome. Thanks for being here. We're hearing some testimony on the child care and early childhood education bill S56. And I've asked some business organizations to come in and talk about S56 and child care specifically. So we're on a tight schedule. We've got about 15 minutes. So we've got 3 people within 15 minutes, which I will be closing out your testimony if you get to the 5-minute mark. Thanks for being understanding. Dimitri Garter is here from the Business Roundtable. welcome. Yes, please. And then why don't you, so we're going to quickly introduce ourselves to everyone. Senator Carrios, over to you.
Hi, how are you? I'm Ruth Hardy.
Terry Williams, Senator from Rutland.
Ginny Lyons, Senator representing Chittenden Southeast.
Dave Weeks, representing Rutland County.
Martine Q, representing Chittenden Central.
All right, great. And for the record, Dimitri Garter with the Vermont Business Roundtable. And I really appreciate the time today. I hope you don't mind, I brought my family. So
We're glad you brought your family.
teaching them
We
about the
love that.
legislative process. And I
Welcome.
really enjoyed that. So
Awesome.
thank you for accommodating. So I co-chair the Early Care and Learning Task Force for the Vermont Business Roundtable. I am also a co-founder and CEO of Global Z International. We're a software company located in Bennington. So I'm an entrepreneur of 34 years. I'm on the Building Bright Future State Advisory Council as the business rep and on the board of my local child care center as well. So I look at the issue through a number of different lenses. But as my role co-chairing the Vermont Business Roundtable, the roundtable is, we're not an advocacy group, we're a networking group of 100 Vermont CEOs, formed really with the mission of harnessing the intellectual power of business leaders to solve some of the greatest challenges in Vermont. So we really take a very holistic view of issues that affect all Vermonters through a business lens, but fairly balanced view. So I'm here representing that group, and the Vermont Business Roundtable has been interested and an active participant in childcare for over 20 years. So this has been one of our most significant policy planks since well before my time on the roundtable. And we are really excited to see childcare front and center on the policy agenda for this year. So we're really, really grateful that this has made the progress that it has made so far. Our view of the bill is there are a lot of things that are really exciting about the bill. The fact that it expands access in particular is something that we really strongly support. The expansion of the CCFAP subsidies is really important for more families to access. Our general philosophy about childcare is that the childcare should be as available and accessible to as many families as possible. And I'll talk a little bit about the funding aspects of that, although I understand that that's not squarely in your purview, but the expansion of the CCFAP to include families up to 450% is, we really are excited about that. Some of the challenges that we see, and not insurmountable, but the things that we're looking at, the cliff at 450% of federal poverty level is problematic for higher income families. Once the subsidies start to increase, the cost of care goes up, we recognize the importance of that happening because we know that investment in childcare infrastructure, particularly around quality, is critically important. And we're focused on the quality components of childcare investments because we recognize that only with high quality childcare will we see the benefits that we want to see from childcare. And those are, by the way, we view that from the workforce perspective. So we see obvious benefits to improving access and quality of childcare to the workforce benefits, but we also see it as critically important from the standpoint of social and mental development of children and improved economic outcomes for children later on in life. So we really do view this as the right thing to do for Vermont families and Vermont children. And quality is a critically important component to that. So with the cost increasing to providers, the cliff, it more than doubles the cost of childcare for families just above that 450% level. And I realize that sounds like a lot of money to a lot of families, but our calculations show that could increase, without any subsidy, that could increase the cost of care to somewhere between 20 and 30% of household income for those families. And, the RAND report sort of made the assumption that families above 500% of FPL would just pay out of pocket. And I don't think that that's a safe assumption. I think that a lot of those families would simply opt out of the system. So, and that's a concern, because not only for the health and well-being of the children, but also the potential impact on the labor force. And particularly with larger employers, that income range, a lot of their employees would be in that income range. And we feel strongly that they should benefit from the system. So that's one concern. And we would encourage the committee to look at ways of expanding the subsidy into the higher income families. Maybe we don't meet the objective of 10%, limiting household income cost to 10%, but is there a way to extend the subsidy schedule up on a slope further up into those families? And then the other concern, which I realize is not squarely in your purview, is around the funding, and just understanding that that's really not the target of this committee. It does affect aspects of capacity and demand in the system, how it's funded. The Roundtable is a member organization. We have a pretty diverse audience, so we really don't have consensus on any particular source of funding. I think our primary interest is in ensuring that funding is spread. The impact of the funding is felt as broadly as possible. So we believe that childcare should be as accessible as possible, but the impact of the funding should be as broad as possible. So, and in particular, I think if employers were asked to bear a disproportionate share of the cost, I think there would be some pretty significant concerns about that. So we believe that this should really be equitable, and the returns should be equitable as well. So, and then the last concern is really about the sort of the concept of moving the pre-K for fours into the public education system. I think it's a really interesting idea. It's not something that we've really considered in depth, and it's certainly worth consideration. We're also aware that there are some transitional impacts on private providers and perhaps families and children as well. So while we think it's worthy of consideration, we're also cautious about understanding what the transitional impacts might be. And I know that you've been hearing a lot of testimony about that. So, we just want to echo that that's something that, as I said, I'm on a childcare board myself, and I know what the impact would be, not just on the providers, but on the families that could have actually harder access issues or affordability issues. So appreciate the time today. Happy to answer any questions. I know.
Perfect timing. It's 5 minutes. What I'm going to suggest is we hear from the other folks,
Great.
and then we'll allow for questions. And I think we're going to have questions outside of it, just to get super quick. Go
Yeah,
for it.
is your app, when you talk about access to the pre-K, are you specifically talking about location, geographical access?
No, not in particular. I think access just in terms of availability of childcare at the hours that parents need. And it's a complicated issue, and there are a lot of factors that impact access. And I know that those are really difficult issues that we're balancing, but we're looking.
A lot of them. Yeah,
Of course.
so I
Yeah,
just
there's
wanted
a
to
lot.
clarify. Yeah, thank you.
Thank you.
Thank you, Sam.
And thank you for bringing, thank you. You guys are great.
Yeah.
Thank you for taking care of your dad.
Absolutely.
This is great. We appreciate it.
That's Angie Harbin.
I had Roxanne Vogt on next. And she's up on the screen. And then right after that, we're gonna try, we're a little bit behind, but go ahead. Roxanne, are you here?
I am here. Let's see. Here we go.
Our time is getting short, so. And if you, for all of you and each of you, please send your testimony in writing to Alex, and then we'll have a record of that. Yep. Go ahead, Roxanne.
Okay. Well, thank you, Chair Lyons and members of the committee, for the opportunity to speak with you today. For the record, my name is Roxanne Vogt, and I'm the Executive Director of Vermont Businesses for Social Responsibility, or VBSR. For over 30 years, VBSR has championed business as a force for good. We leverage the power of business for positive social and environmental impact, and we do that through education, networking, and advocacy. We have 700 members across the state, all sectors and sizes of business, geographic regions, from sole proprietors to the largest employers of the state. So that's VBSR. Dimitri did a great job of speaking to some of the specifics of the bill at hand, and he's also been a strong advocate for the importance of this issue. We're proud to call Global Z one of our VBSR members. I'm going to share some contextual history and anecdotes on behalf of our members. So starting with, I recently came across a VBSR policy statement entitled Childcare, an Escalating Business Issue. And it spoke to many points those in this room are familiar with. The neuroscience of birth to 5 and how children who can't access high quality care are so-called stalled at the start in terms of not just educational outcomes, but their ability to thrive as adults. The impact on employee productivity and therefore business growth when working families can't access the care that they need. And then of course, the interrelationship between access, cost, and quality. That VBSR policy statement was written in 2003, 20 years ago. In 2013, 10 years ago, I joined VBSR as a staff member, and through our work on childcare, I became aware of the high cost of care and the lack of infant spots in particular. I myself spent 4 years planning for the birth of my daughter, and still, when she was born, juggled for 5 months not having care. Until I finally got that call that there was an infant spot available. And I just want to share a little bit about what that was like. Here was the call. We have a spot for you. You need to bring $50 as a deposit. Whoever gets here first gets the spot.
Gosh, wow.
Oh my gosh.
Now, I had the $50 check. I had the checkbook on me because I've been waiting for 4 years. And I had the flexibility from my employer to drop what I was doing and race over there. I got there. I was fortunate enough to get the spot. But let me tell you, I knew that there was another mother who needed it just as much, if not more than I did. And that still haunts me. What happened to that family who didn't have the flexibility, who didn't have the $50? So that's just a personal anecdote. Now, here we are in 2023, 2 decades later from VBSR's first policy statement on childcare. And clearly we're facing a credible threat to the health of our economy. People are opting out of the workforce, choosing not to have children when they would like to, and choosing to move out of Vermont or not come here because they can't access the care that they need. So clearly we have moved beyond an escalating business issue to a full-blown crisis. And I want to share just a couple of anecdotes from our members. So Sam Hooper, who's president of Vermont Glove in Randolph. When I look at the barriers to success for Vermont Glove, childcare is top of the list. We operate on thin margins. When one employee can't make it in because of childcare, I know it's going to be a long day and our productivity will suffer. We absolutely must create a childcare system that works for every family as well as our businesses. And this from Kara Tobin. She's chef and owner of Honey Road in Burlington. This one is tough. It was easier to open a restaurant than it was to find childcare. And every day, my restaurant is impacted by the instability of our childcare system. So those are just a couple of stories from our member businesses. In aggregate, I've also heard many stories of employers who unfortunately are considering the painful decision of letting employees go because they're missing so much work due to the lack of reliability in childcare. And you can imagine how tough that is when it's already so difficult to actually get those workers in the first place.
Roxanne, I'm gonna
Yes.
ask if you could please submit your testimony in writing, because I would like to hear from the last witness we have on our schedule. We're due up on the Senate floor in just a few minutes, so.
Got it.
I really appreciate your taking the time to be here with us today.
Great. Well, thank you for the support of the committee. We are in favor of the bill. We would like to see families be able to access the care where and when they need it.
Yeah.
I'd be happy to answer questions wherever that would be helpful.
We'll do that, and if time allows, we'll try to have you back in to
Great.
complete your testimony, but if you can send it in writing, that would be great. And I do know that Senate Economic Development Committee is also taking testimony, or has, regarding childcare and business, and so this is helpful.
Excellent. Thank you to the committee.
And we're moving on to Megan Sullivan, Vice President of Government Affairs. She's not here. Who is here?
Angie Hardman with Down Street Housing and Community
Oh,
Development.
well, here you are. Oh, you're from the Housing and Community Development. Thank you.
I am.
Great.
So it's interesting, these threads, everything I'm hearing about childcare, I could almost say about housing. I moved to Vermont in late May, and it's easier to run a housing organization than it was to find housing. So thank you so much for giving me a few minutes to speak, and I'll try to keep it brief. I'm Angie Harbin. I'm the Executive Director of Downstreet Housing and Community Development. I have submitted remarks that say a little bit more about what Downstreet does, but in a really quick nutshell, we are an affordable housing developer. So we develop, own, and operate permanently affordable multifamily housing. We also provide services to our residents to make sure that they maintain housing stability. And we offer a full array of homeownership grants, loans, and services, and we facilitate permanently affordable homeownership opportunities. And so I'm here today to advocate for full funding for the Vermont Housing and Conservation Board. And I'm excited to speak to this group because I'm really passionate about the concept of housing as healthcare. I could go on and on about that. And as I'm trying to quickly reformat this spiel, I think I should start with just sharing a proposed project. So this project, despite the amount of work and money that's already gone into it, is still just an idea waiting to be fully funded. In fact, we submitted our application to VHCD just a few weeks ago. So for the better part of 2022, Downstreet has been working with individuals with intellectual and developmental disabilities and their caregivers, trying to figure out how we find or create safe, independent housing options. A lot of folks they've got aging parents, they're looking at unstable housing in the very, very near future. And we're hoping to see these efforts translated into reality with a new 26-unit affordable housing project that we're planning for Waterbury. So this project will be built on an underutilized parking lot on Main Street in Waterbury. There's public transit across the street, easy walking access to green spaces, to employment opportunities and other amenities. And so the idea is that we set aside 3 of the units in this affordable housing complex for people with intellectual or developmental disabilities. And then there are on-site services that will be staffed by Upper Valley Services. So these individuals will be employed, they're in the workforce, but they cannot live independently without additional support. So Upper Valley Services will provide up to 24/7 of on-site support, so these individuals are able to take advantage of affordable housing. This replicable congregate care model, or cluster model, I'm sorry, it's easily incorporated into the way that we build multifamily development. And it also enables people with on-site service needs to, one, live independently, but also to economically share in the staffing costs of service provision. So it's a win-win, and we couldn't do that without VHCD funding. I also want to highlight.
So we're being called.
Okay.
We understand, and
amazing.
you're speaking to us who have been requesting designated housing types based on healthcare needs. So thank you for
Sounds
the work that you're doing
It is
very much.
an amazing model. Thank you
And
so much for
please
the time.
send it in.
I will send more of these. You
Okay.
don't think you have the story, so I'll send it
Send the
back.
story. This is a good story. Thank you.
Perfect, thank you.
And is this Alex?
Yes,
Thanks for your help, Alex.
of course, I'm taking this offline.